Thank you for the invitation and for the title, which I didn't choose, because the title has some implications that are, so far to what I know, very difficult to address, because in pre-symptomatic vulnerable patients, it means patients that did not have coronary disease before. So it's talking about primary prevention. And in this term, there is nothing that I know that can tell whether one patient will be a different type from another in terms of what is described by traditional risk factors. So I'm a clinician. I'm used to see patients. I still see patients. I still keep being surprised by how patients present to me. And I try to learn from what they are trying to teach me. Not necessarily succeed, but I try. So, this one. Okay. So you see, one of the problems that we are confronted when we have used risk stratification, and here I put the Framingham score plus CRP, or LDL cholesterol plus CRP from this review from Paul Ritke. We are facing the fact that we see a very remarkable stratification of risk from these patients with low CRP and low Framingham score. It's about 1% risk in 10 years, to these two with high CRP and high Framingham score that's more than 20%. However, there are 2 points that to a clinician are very embarrassing. The first is that these that had events in 10 years, there was no way that I could predict who was going to have it within 1 month, or within 1 year, or within 9 years, or within 10. The second is that after all what I've done here, about 80% of patients in 10 years have absolutely nothing, which is remarkable if you think that these are the highest risks that you can stratify. So you see, the problem is that in these patients, if we add anything, it will be difficult to identify those that are at risk in this low-risk group because of the Bayesian theory. You know, it's very difficult to identify those at risk. So we can hope to identify here some of these that are at greater risk. And now how are we going to do it? You heard before that some of these people that get the first heart attack don't have critical stenosis. So if we had the coronary angiogram the day before, we could not have predicted that they were going to have a heart attack. Now, if we can find plaques that are going to become unstable, that is a problem because we have difficulties in distinguishing a number of things when we see something. We have difficulties in defining what is a mountain which will never erupt and what is a volcano that sometimes may erupt. And we only are good at identifying volcanoes when they are erupting because we see them. They have thrombus on top. They create trouble. They get symptoms for the patient most of the time. But if they don't erupt and they erupted in the past, then it becomes difficult again. It's like recognizing some volcano which has erupted 100 years ago or 500 years ago, and we don't know what's going to do next. So we have a difficult problem. However, if we try to learn from what patients try to tell us, maybe we can very humbly take a new tack, change the sails according to the wind. And the problem is we are talking about atheroma and atherosclerosis and identify the total atherosclerotic risk. Well, I'm impressed as a physician that some patients have a lot of atheroma and yet they didn't have an infarction, and others have very little atheroma and they had an infarction. But I'm even more impressed by the fact that some patients have an infarction, have their atheroma, and then for years and years have absolutely nothing, with the same atheroma staying there, the same atherosclerotic burden. So I think that on average we go on what we always learn, but if we want to move ahead, we have to start thinking along different lines and try to understand what triggers an acute coronary syndrome, unstable angina, heart attack. if this is not linearly related with atheroma, because it's not. At least all clinicians know it's not. On average, yes, but in clinical practice it's not. So in other conditions, subtle difference in clinical presentation and phenotypic features may provide clues suggestive of specific causes of clinical syndrome. In anemic patients, clinical history and red cell features can provide useful information on specific causes of anemia, which you wouldn't have if you only measure hemoglobin. And we do this most of the time with patients with ischemic heart disease, because in epidemiology we only measure heart attacks or coronary death. When we do angiography, we measure stenosis, but it's only one thing. And I ask myself, could this be the case also for patients presenting with acute coronary syndromes? And always listening to patients, this could be the case, because there is a spectrum of clinical presentations for patients that come in with acute coronary syndrome or heart attacks. At one extreme, you must have seen patients like this, that the patient presented with an infarction out of the blue sky, preceded and followed by complete stability. If the patient denies having had anything before, you can always say that the patient doesn't know, that he's stupid because he doesn't tell me what the books are telling me that he should teach me. But that's not the case. And it's followed by complete stability. The patient may not have anything for the next 10 years, 20 years. At the other extreme end of the spectrum of presentations, you have this other patient, type 2. The patient has unstable angina, followed by infarction, and followed by recurrent acute coronary syndrome, post-infarction angina, new infarction. And you must have seen these patients. And you know unstable angina is defined unstable if it happens up to 2 months before admission, and then can remain unstable for a few months later. And if you look at the Duke database, you see that mortality following infarction or acute or unstable angina decreases gradually following discharge for the first 6 months and reaches that of stable patients only after 6 months. So there is a transient, prolonged period of instability in patients that had an acute coronary syndrome. But is this period of instability equally affecting all the patients, both type 1 and type 2? Well, it does not appear to be like that, because these patients, type 1 and type 2, appear to have also some biological difference, not only clinical difference of presentation, but also some biological differences. Here, for example, if you look at patients, of course, patients have to be very well characterized. These are patients with Brownwell class 3B unstable angina. 65% of these patients have elevated levels of CRP. But of course, it's patients with persisting unstable angina, like in Brownwell classification 3B. Now, a complement to this is that patients that have an infarction, but the infarction was preceded by unstable angina, it practically 100% had levels of CRP on admission higher than 3 milligrams per liter. But if you compare patients that had infarction not preceded by unstable angina, only 45% had elevated values of CRP and interleukin-6 on admission. And this was published in this paper with Giovanna Riuzzo in 94 on the New England, and repeated in another study published on JACC in 99. So it looks like a majority of patients with persisting unstable angina have elevated C-reactive protein independently from having elevated troponin, because those patients were excluded. So this was the first study where CRP was shown to be associated with persistent instability and infarction independently from elevated CRP, elevated markers of necrosis, because we excluded all the patients with elevated troponin. And by conversely, all the patients that in whom infarction was preceded by unstable angina had elevated CRP on admission within 6 hours, whereas only 45% of patients presenting with an infarction just out of the blue, not preceded by unstable angina, had elevated CRP. But the story goes on. Here, persisting CRP elevation post-discharge predicts recurrent instability. This is the paper we published with Luigi Biasucci on Circulation 99. And this is a similar paper in a follow-up study by Peter Bogarty in Canada, published on Circulation in 2001. So these patients that have tending to have recurrent events tend to have elevated inflammatory markers, CRP or interleukin-6. And this is the paper by Biasucci. You see that on admission, patient with Brown class 3B, 70% had elevated CRP, but not 100. So patients are not behaving homogeneously because probably they are not homogeneous. At discharge, 50% nearly have elevated CRP. At 3 months, over 40%. At 1 year, nearly 40% continue to have elevated CRP and interleukin-6. Now, these are patients with low levels at discharge, lower than 3 milligrams, and these are with levels higher than 3 milligrams. You see these, the event-free survival is markedly better in those with low CRP. So these patients presenting with low CRP with unstable angina have smaller incidence of events than those that have elevated CRP. And here there are two interesting studies that says that those patients that have primary angioplasty for infarction, the paper by Goldstein in New England, and have multiple unstable coronary plaques, those that had multiple plaques were more likely to come back within short time with a new infarction or new unstable angina. So multiple plaques in the study by Goldstein were associated with recurrent instability. Here in the paper by Zairis on atherosclerosis, the higher number of unstable plaques were correlated with higher levels of CRP. And in this paper that we published with Antonino Buffon in the New England in 2002, that paper showed that there is widespread inflammation in patients that have unstable angina and Brown class 3B unstable angina. So that's not only the case, but this is a paper that has been just submitted, has been presented last year by Antonella Lombardo from our group, that shows that carotid plaques are more often complex in patients that have unstable angina and elevated CRP than simple plaques. In patients with low CRP, carotid plaques are more often simple, are no plaques or simple plaques, and very seldom in in patients with low CRP there are complicated plaques by echo in unstable patients with low CRP. So it looks like there is, in those patients that have persistent recurrent instability, have multiple plaques in the coronaries. How can you identify which one will become the culprit lesion next time? Which one should be stented? Not only, but it looks like they have complex plaques also in the carotid. So it's a systemic problem. But you see, it's a systemic problem that doesn't last forever. It's not related to atheroma, because eventually, after 3 months, after 6 months, after 2 weeks, after 1 year, then it dies down. Yet the atheroma remains there. But this is like a storm that happens in these patients and is related or associated with this systemic inflammatory detectable things. I don't know whether this is related causally to CRP or that is just a marker of something. It's most likely, in my opinion, a marker. So the mechanism of inflammation in during these acute coronary syndromes could be infections and non-infectious agents, bacteria, viruses, oxidants, toxins, immunological stimuli, as shown in these papers that we published with Giovanna Liuzzo in Circulation, 1999-2000, with Pina Caligiuri and Goran Hansen in 2000, with Gigi Biasucci in Circulation 203, where we found antibodies against heat shock protein 60 of chlamydia in patients with acute coronary syndromes, but not in stable patients. And then what is common in this group of patients that have elevated CRP, persistent elevated CRP, persistent elevated interleukin-6, is that they have enhanced inflammatory responsiveness to stimuli in vivo, like coronary arteriography, the stimulus of catheterization, or angioplasty in this paper with Giovanna Liuzzo, or to the stimulus of myocardial necrosis for the same paper, the same with Giovanna Liuzzo. And here with in monocytes ex vivo, that they respond to lipopolysaccharide by producing much more interleukin-6 than the monocytes of patients who do not have elevated CRP and interleukin-6. So, in conclusion, in acute coronary syndromes, inflammatory response is largely independent from the global atherothrombotic burden. In some patients, but not in all, plaque instability may be prolonged in time and involve multiple vascular sites. So you see, if we have to deal with this problem from a different angle, what do we need to do? We need to learn more. We have first to walk and then to run. We are immediately thinking, how are we going to prevent these patients? We cannot prevent them before we understand what's going on. I'm only trying to tell you that there is something that goes on, but it's not necessarily the same in all patients. Inflammatory mechanisms are correlated with recurrence instability. They may be multiple and not equally important in all patients. We have to admit that patients may differ from one from another. The precise identification of these mechanisms is required for targeted prevention of inflammation. Otherwise, certainly we cannot give steroids. I wouldn't, personally. Inhibition of key inflammatory final triggers of thrombosis appears an attractive therapeutic target, and patients with recurrent instability and elevated inflammatory markers are ideal candidates for pilot studies. The problem is that if you want to explore the triggers of acute coronary syndrome, clinical investigators should stop being lumpers and become splitters, looking for distinctive rather than for common features among patients presenting with coronary atherosclerosis and acute coronary syndrome. Just to give you an idea, this is an image. And what do you see there? If you look, it's very confusing. But if you look at the extremes, you see clearly a bird. And if you look at the other extreme, it's clearly a fish. In the middle is a mess. But if you don't start looking at the extremes, you will never understand the composition of this picture. And I think that for what causes acute coronary syndromes, in my opinion, it may be more complex than this picture. Thank you very much.